Hypertension. Our blood pressure is the force that's produced by the volume of blood in the arterial walls. Blood pressure equals our cardiac output multiplied by the peripheral resistance. Blood pressure will be raised and lowered by neural, hormonal, and chemical mechanisms and through vasodilation and vasoconstriction. Measuring our blood pressure reflects the ability of the arteries to stretch and fill with blood, the efficiency of the heart as a pump, and the volume of circulating blood. Blood pressure will also be affected by our age, body size, diet, activity, emotions, pain, position, gender, the time of day, and disease status. Blood pressure is measured with a standard sphygmomanometer and stethoscope, and it's expressed as a fraction. The top number we know is the systolic blood pressure, with the bottom number being the diastolic blood pressure. A normal blood pressure for adults will range from 100/60 to 119/79. To obtain a realistic idea of the blood pressure, we actually need several measurements to be obtained for comparison. The autonomic nervous system, the kidneys, and various endocrine glands are going to help regulate that arterial pressure. Blood pressure usually will increase with age because of arteriosclerotic and atherosclerotic changes in the blood vessels or other effects of chronic diseases. For example, diabetes and renal dysfunction. Systolic blood pressure is determined by the force and volume of blood that the left ventricle ejects during systole and the ability of the arterial system to distend at the time of ventricular contraction. Older patients may have an elevated systolic blood pressure, once again due to arteriosclerosis or that hardening of the arteries. Arteriosclerosis causes vasoconstriction, which increases peripheral resistance, and that in turn will increase the systolic blood pressure. The diastolic pressure is the arterial pressure during ventricular relaxation. It's dependent on the resistance of the arterioles and diastolic filling times. If the arterioles are constricted, blood is under greater pressure. With our central aortic systolic pressure, CASP, this is a method of determining the blood pressure that might be a better predictor of vascular and cerebral complications than the brachial arm pressures. But it may not be practical because it does cost a lot to do this. The pressure of the blood at the root of the aorta is taken as blood is pumped from the left ventricle. And then we have an invasive measurement done by passing a catheter from the femoral artery to the aorta or by a CASPRO computerized monitor. The nurse is educating clients at the community center on the risk factors of developing hypertension, and this is abbreviated HTN, all capitals. Which of the following is considered at the highest risk for developing hypertension? Obese adults, older adults with diabetes, adults who exercise twice weekly, older adults with glaucoma. This is going to be your older adults with diabetes. We've already said that diabetes is one of those comorbidities that can cause an increase in blood pressure. but also uh, our older adults are at an increased risk because of the arteriosclerosis. So hypertension is defined as high blood pressure, and it's also called the silent killer. 1 in 3 adults have hypertension, but only 52% of adults are aware or have their blood pressure under control. Risks of hypertension include heart disease, heart failure, stroke, and kidney disease. So we have several definitions, and those definitions are going to include prehypertension. Prehypertension is defined as a systolic blood pressure between 120 and 139 and a diastolic blood pressure between 80 and 89. Stage 1 hypertension is a systolic blood pressure of 140 to 159 or a diastolic blood pressure between 90 and 99. Stage 2 hypertension is defined as a systolic blood pressure greater than 160 or a diastolic pressure that is greater than 100. Hypertensive heart disease is when the elevated blood pressure now causes a cardiac abnormality. We can have hypertensive vascular disease where the vascular damage is present without heart involvement, or we can have hypertensive cardiovascular disease where both heart disease and vascular damage are accompanied by hypertension. We may also see what we call essential hypertension or primary hypertension. 95% of clients with hypertension have essential hypertension, where we have a sustained elevated blood pressure with no known cause. Causes, once again, are unknown, but can also be caused by age or familial connections or by being African American. They have a higher risk of hypertension than other ethnicities. Risk factors for essential hypertension include obesity, inactivity, smoking, alcohol intake, ineffective stress management, hypernatremia, alterations in body chemicals, or impairment in the renin, angiotensin, and aldosterone mechanism. Secondary hypertension is an elevated blood pressure that results from or is secondary to some other disorder. Causes include any primary condition that will affect fluid volume or renal function. So risk factors for secondary hypertension include kidney disease, pheochromocytoma, hyperaldosteronism, atherosclerosis, cocaine use, cardiac stimulants, and oral contraceptives. But we also have what we call the white coat hypertension, where we have an elevated blood pressure that develops during evaluation by medical personnel. The client gets tense, they get nervous, they get anxious, and their blood pressure goes up when a doctor or nurse is there. Overall, what's happening is hypertension is damaging the arterial vascular system. So it increases the fragility of the veins. It makes them weaker. It can accelerate atherosclerosis and can cause complication in other body organs, especially the eyes, the brain, the heart, and the kidneys. So these clients Again, a lot of them don't even realize they have hypertension because it has a pretty gradual onset the majority of the time. But some of your general assessment findings will include a throbbing or pounding headache, dizziness, fatigue, insomnia, nervousness, and nosebleeds. The size of the heart muscle is going to begin to increase and they may develop heart failure. We may see myocardial ischemia that can lead to myocardial infarction, angina, or dyspnea. We may see hemorrhage of tiny arteries in those eyes, which is going to lead to blurred vision or maybe papilledema. We may see the CVA or the stroke, the cerebrovascular accident, and we may see kidney failure. We can diagnose with electrocardiography, echocardiography, chest x-rays, multiple gated acquisition scan, blood tests. Again, we would be looking at our renal labs. We'll be looking at the BNP to see if we have any heart failure going on. We would also be looking at our cardiac enzymes to determine if there's any elevation. And we may also be looking at a lipid profile to determine what the cholesterol levels are. We can do an IV pylography, a fluorescein angiography, an ophthalmologic test using IVD, a renal arteriography, or a 24-hour collected urine specimen. Non-pharmacologically, we can treat this client that may have prehypertension. But if they go beyond prehypertension, then we may include other interventions. Excuse me. Those non-pharmacological interventions would include weight reduction, decreased sodium intake, moderate exercise, reducing or quitting smoking and alcohol use. Again, drug therapy treatment would depend on the stage of the hypertension. A lot of times, diuretics are used to help decrease blood pressure, especially your thiazide diuretics. Most people are going to require 2 or more antihypertensive medications to reduce their blood pressure. And if their blood pressure remains elevated, a 3rd or 4th antihypertensive agent might be added. And there's a multitude of medications, and I will let you go through these medications yourself. However, I want to point out that as you're looking at these medications, our beta blockers are medications that end in olol. So if you look at the examples, it's going to be your atenolol or your metoprolol. The adrenergic drugs, again, I'll let you look at those. The ACE inhibitors are going to be those medications that end in pril. So as nurses with management, we should take blood pressure in both arms initially with the client in a supine, sitting, and then standing position if we are assessing potential hypertensive disease. We should encourage the client to follow the treatment regimen, obtain additional cardiac assessments, make sure that we have an accurate medical history and a list of the current symptoms. We're going to look at non-pharmacologic and pharmacologic methods for restoring and maintaining their blood pressure. So regardless of the stage of hypertension, We would encourage weight loss. We would encourage the low sodium diet. We would encourage the increased activity and smoking cessation and limiting the use of alcohol. We would also talk about techniques for self-management, encouraging the client to collaborate with their dietitian and eat the DASH diet. Stress reduction can help reduce blood pressure. Which condiment would the nurse recommend to a client with hypertension who's on a low sodium diet? That would be lemon juice. Accelerated and malignant hypertension can develop in clients with essential or secondary hypertension. Accelerated hypertension, we have markedly elevated blood pressure that's accompanied by hemorrhages and exudates in the eyes, and is what we consider a hypertensive crisis. With malignant hypertension, we have untreated accelerated hypertension, and then we start seeing dangerously elevated blood pressure accompanied by papilledema. This is going to occur in clients with undiagnosed hypertension or those that fail to follow up or comply with medical therapy. It often has an abrupt onset, and if it's untreated, severe symptoms and complications will rapidly follow. With malignant hypertension, this is fatal unless that blood pressure is quickly reduced. The kidneys, brain, and heart can be permanently damaged, even with intensive treatment. And the arterial blood vessels may rupture or might rupture soon. We may see retinal hemorrhages that can lead to blindness. Strokes may occur. Aneurysms may burst and cause hemorrhage and shock. Pulmonary edema or myocardial infarction or renal failure may also occur. These clients experience confusion, headache, visual disturbances, seizures, coma. We see a rise in the blood pressure that can cause chest pain, dyspnea, moist lung sounds, and renal failure. They may have severe back pain, excuse me, accompanied by hypotension. Aortic aneurysm might be, with that severe back pain, an aortic aneurysm might be dissecting or rupturing. The systolic blood pressure is 160 or higher. Diastolic is 100 or higher, or both. The optic nerve will appear to bulge forward and retinal blood vessels are going to be obscured. The goal is to lower that blood pressure within 1 to 2 hours, and we do that with IV medications. Diazoxide, nitroprusside, nitroglycerin, labetalol are some of those medications that we may give. We can also give oral medications for the less critical clients, such as nifedipine, verapamil, captopril, or prazosin, and definitely oxygen to reduce hypoxia-induced tachycardia. Nurses are going to implement medical orders promptly, mix drugs with IV solutions after carefully calculating the dosages, check the site and progress of the infusions at least hourly, and administer automatic blood pressure recording machine. So they're going to be automatically obtaining and recording the blood pressure. Report systolic pressures of 160 or higher, diastolic pressures of 115 or higher as soon as possible. Restrict the client's activity. monitor for neurologic, cardiac, and renal complications, and keep emergency equipment and drugs ready in the event of complications. A 38-year-old man has hypertension. He's interested in starting an exercise program. What form of exercise would be best for him? Bicycling. And your post-test.